Hi, welcome to episode 3 of the Rubaiyat Khan for Endless Health podcast. Today, I have the pleasure to invite two really old friends and people I admire a lot to talk about integration of care. Welcome, Nachiket and Saul. I think I have known each of you for over 10 years now. Saul, you are a kindred spirit, serial entrepreneur in the health tech space and a maker at heart, just as I would describe myself as well. Since I met you at the Bulago Fellowship almost a year ago, almost a decade ago, you went on to build one of the most successful health tech companies in Africa. Healthforce brought affordable healthcare to 6 million South Africans by lowering the cost of care by 75%. You recently exited by selling to a large African pharmacy chain, and you're also recently an advisor to our portfolio at Endless Health. So, welcome to my podcast.
Thanks, Rubaiyat.
Great to have you here. Nachiket, I met you first probably around the same time when you were leading the Gates Foundation team in India. You were trained as an economist, again, like me, but spent most of your career in practice and policy before moving to the world of academia. Currently, you're a visiting scientist at the Bunyan Academy of Leadership in Mental Health and a visiting professor at the Indian School of Business. What I've admired most about you is how policy and practice oriented your research has been, which is quite rare. And I've also had the pleasure of collaborating with you on a few of these research pieces in the last few years. So, really excited to have you here as well. Welcome.
No, happy to be here. Happy to be here.
So, I think it is fair to say that today's conversation is about bridging research and practice because you both are at the frontier and leading edge of this and try to show some practical paths forward for addressing fragmentation and for integrating care. So before we start, I have to admit that I actually come at this quite naively. So having spent most of my life and career in Bangladesh, where I built multiple health companies, Bangladesh is a out-of-pocket free-for-all market, like many others. And now in the US, where I live, I've recently had to spend 3 months coordinating between my doctor office, my pharmacy benefits manager, and my insurance to even get one prescription filled. I'm quite keenly aware of the myriad costs of fragmented care from a patient perspective, but I honestly don't really have an intuitive grasp of the various approaches to integration of care that have been successful in other markets. What are their various pros and cons, and what really enables them to work? So that's what I really hope to get into today with the benefit of having such experts as yourselves amongst us today. So I want to start by setting the stage a little bit and to try to break it down in a way that even a 12-year-old would understand. So, Nachiket, from the perspective of a patient or let's say a government payer, what problem is integration supposed to solve within the health system?
I mean, I'd be keen to hear what Saul has to say about this, but my understanding of integrated care, of course, when you say government as a player, government could be a provider as well. So at the moment, let me stick with somewhat of a private sector background so that we are clearer what we're talking about. Um, to me, there are two big things that integration does. One is it allows you a lot more continuity of care. So that if you are somebody that started with a stomach ache, ended with colon cancer, you have the ability to go up and down that stream in a smooth way without getting lost. The second benefit I see is if it works well, you are reasonably confident that the provider has your best interest and that they are not doing a procedure because for some reason, doing whatever it is that they are doing benefits them, even if it's maybe doesn't benefit you or on balance, it might even hurt you. So I think that's the other big opportunity that integrated care can actually provide. And one kind of corollary of this is that sometimes you yourself may be actually the least qualified. And this may be hard to see from an American point of view, where Americans are all about free choice. You may be not as well qualified to look after your own health. And you might, for example, wish to have a C-section to deliver your child because you think that's good for you for whatever reason. The thought is that an integrated provider actually reaches out to you because not, I mean, partly they may care about it, but partly financially, it's in their interest. Again, with the big caveat, if it all works well, to keep you healthy and to persuade you to do things that are in your best interest. Not because they are necessarily good people, they may well be, but it's because financially, this is really what benefits them. So I would say these are the two benefits.
Thank you, Nachiket. I think I heard themes of like patient agency and autonomy. There's questions about whether integration, because when you talk about continuity, integration is one approach, but there could also be a coordination approach across more fragmented providers. So that's something that I want to touch on today. And I also heard the incentive alignment piece, right? Because that's where financing comes in, and it's really hard to separate financing from integrated care. So that's the other piece that I want to touch on today. So coming back to Saul, Nachiket talked about getting the provider to care about the patient's interest, right? And I want to kind of come back to you as someone who's built a provider network. How is the fragmentation problem actually faced on the provider side? And is integration the right word even for what you were trying to achieve with Salesforce?
I really love the way Nachiket put that. The clinician wants to do what's best for you. And I think underlying what he said there was a story about incentives and what the incentives are in the system that drive the clinician's behavior. I've met very few clinicians, if any, that really want to do ill by their patients. But often because of insurances, because of isolation in the system, and for various other reasons, they may take a suboptimal approach for a patient. So I think that the question of getting the incentives right in order to result in some kind of care continuum that Nachiket spoke about, it goes hand in glove. But it is more, I think, the mechanism to drive the system towards integration than the outcome in itself. The problem that providers face, to your question, when it comes to wanting to work together through some kind of overarching care coordinator or in some kind of integrated manner, is that the incentives in the system often work against them doing that, or work against external parties coming and coordinating across them on their behalf. It is a supply side engineering problem that is created by the wrong incentives. So where providers can see the benefits of working together, they struggle to do so because they cannot unlock the value that they need in order to make a living by doing so. And this is somewhat of a chicken and egg situation. For the payer to pay the providers to deliver integrated care, the providers need to organize themselves in an integrated manner. But for the providers to organize themselves in an integrated manner, the payer needs to pay for integrated care outcomes, which, to be honest, is better health outcomes at the same cost, or same health outcomes at lower cost, or some combination thereof. So that is the problem that I don't just think providers, the supply side faces. I think it's equally a problem that the payers face. And the question is, where do you start getting some kind of change in the system so that both can change in unison?
Thank you for putting that so nicely. So when you were building Healthforce, was the regulatory environment, was the incentives in the system already aligned for you to build a more integrated model? And how did you kind of overcome that? I want to actually understand the Healthforce story a little bit more for instance sake. I feel like when you say 75% cost reductions, that is only possible when you really optimize the system for prevention, for making sure that you intervene early. Those are the kinds of things that would reduce that much of cost. And without integration, that's probably not possible. So how did you actually engineer the system towards integration even without the right incentives being in place.
South Africa has two parallel healthcare systems. 80+% of the population goes to the public sector funded by government. Less than 20% of the population goes to the private sector, which is pure play fee for service, whether the patient is the payer or where more often the health insurer is the payer. So that's the structure of the system. We were operating specifically in lowering costs in the private sector space. There's a qualifier to the lowering of costs that we achieved, and that is that we didn't lower the cost to look after the whole human being, or for that matter, to look after the full episode that a person might be going through beyond complex diseases. We lowered a cost of a particular part of primary care by that much. We targeted that because we thought that if we could lower the cost of care there, that barrier to entry for the 80% of people who can't access private care would be lower. And those people would be able to get earlier care. And of course, earlier care, primary care, hopefully you don't land up with the complex conditions that result in you needing more specialized layers of the healthcare system. The way we achieved lowering the cost in just that primary care space is a microcosm of what I believe is probably needed within providers across the system as a whole. And that is by organizing teams of healthcare workers and organizing that team around the need of the patient. And that speaks to what Nachiket spoke about earlier, which is sometimes the providers don't organize around the need of the patient. They organize around the incentives in the system, what the payer will pay for, what the employer wants, what the insurance companies are trying to protect for. In the case of Health Force, what did it look like? Well, it meant that we looked around South Africa and we saw that there were something like 3,000 pharmacies with nurse-run clinics in the back that were doing very, very basic primary health care, maybe sometimes as little as weighing babies and doing vaccinations. And we built a piece of software for them that allowed them to call in without having made a booking on demand at the click of a button, a general practitioner via telemedicine connection, via video connection. And then we trained the doctors and the nurses to work together as a team, with the very important third team member being the technology itself, because the technology could do a lot of the heavy lifting. And then it was a case of getting the lowest cost member of the team to perform to the maximum scope of their ability and coordinating the flow of the patient through that consultation across those various team players. So by organizing that team and knowing what the central need of the patient was, we could make sure that whether it was the tech or the nurse or the GP, if and when needed, and then for the shortest amount of time possible, play their role. So I'll give you an example. A patient comes in, they think they need to see a GP. Actually, they find that 80% of the time, the nurse can solve their problem without a GP. Okay, now the cost of care is a fraction of if they'd gone to the GP. Let's just say that 20%, 15%, 10% of the time they need to see the GP. Now the nurse has collected information during that consultation. The technology has prompted the nurse to collect certain information that we know the doctors will need. When the doctor enters the call, it's still not the full price of the doctor, because the doctor picks up from where the technology and the nurse have left off for her or him, and can do a much shorter consultation at a much lower price. So 80% of the time, you're only paying for the nurse. Other 20% of the time, you're only paying for the nurse and a fraction of the doctor's time.
This is quite close to my heart, as you probably both know, because I tried to build a similar telemedicine business that connected rural pharmacies in Bangladesh with urban general practitioners and specialists. And I want to come back to that a little bit, because I feel like what really didn't succeed in the Bangladesh case, after spending 8 years on it from our side, was how informal the nature of the market was, right? And so the pharmacies themselves were often not registered properly with the government. There was very little regulatory oversight. So managing them and stewarding them in this fashion became extremely hard. So that's something that I want to to come back to like what are the prerequisites in the market that actually allows something like this to work. So one question before I move on to Nachiket on various integration approaches is how did you incentivize and finance
Yes,
this
sorry.
system differently?
That's true. Sorry, I didn't touch on that. As I mentioned, it's a chicken and egg situation. And I mean, I was flattered when you said we built the best health tech company in Africa. It was far from it. We were solving just a small part of a very big problem for a fraction of the people that actually need that solution. And so we weren't really able to influence the funders to pay for outcomes. So we hijacked the fee-for-service model by simply lowering the cost and then getting people to come to us because of the lower cost, and then taking the fee they paid and sharing it between the different players in a way that, number one, paid for their time, but number two, incentivized them to work together as a team. So because both nurse and doctor were using our software, we are able to measure certain metrics around patient experience, collaboration between nurse and doctor, wait times for patients, and so on. And at the end of the day, the clinicians were compensated not just based on their time, but based on the behavior that we wanted to see when an integrated team was working, despite the fact that on the other end, we were actually collecting fee for service.
So what you measure is what actually gets done, right? This is kind of proof of that. Nachiket, coming back to you, from what we are hearing so far, it seems like there are some systemic issues that no one provider can potentially address by themselves, right? The financing of healthcare is a big one. The regulatory environment is another one. How mature the market is another one. So, and if we look at like integration models that have worked in countries like Colombia, in Thailand more recently, seems like the government had a key role to play in actually stewarding the market in that direction, right? But we see so few other countries, Bangladesh being a case example that I'm most familiar with, where this is a huge problem. And now we know, of course, with chronic diseases, continuity of care is even more important, right? Like that is causing the vast majority of deaths at this point. Why are not more countries moving in this direction, and why have not they begun this journey towards and stewarded the system toward better integration?
Yeah. I mean, there are two separate questions here. One is, what is the role of the government? And if the government is not actively involved, what can you do? The other is, can people do it without the government? Is there enough room there to maneuver that really government is not the problem, but there are other things that are, possible. And then, of course, the question is, if they are possible, then why are they not getting done? Now, I don't know any market other than India. I don't have an intimate familiarity with it. But in India, I'm somewhat more closely involved in hospital systems, startups, primary care, which me directly. And my view is that really there is a lot of opportunity out there to build. And if you see the paper that I wrote in this journal called Healthcare, I present two sets of ideas as to where we might begin the journey. One is at the primary care level, and one could even pass it a little bit to say we have actually three levels. One is primary, secondary, and tertiary. And potentially one could start almost anywhere. And to my mind, the most promising is the secondary care layer. I think the least attractive is the tertiary care layer. Somewhere in the middle is the primary care layer. I think the primary care layer, in theory, is a layer from which we could begin this journey, but it's much harder because, in some ways, they may lack the critical mass that is needed to build the structure that is needed. They may lack access to capital. They may not have the brand, etc. But I think a lot is possible to do amongst these layers that are there. I think for the government to change the public sector to do, clearly there is an opportunity for the government to do this as well. And, you mentioned Thailand. That was one of the areas in which I think Thailand succeeded quite nicely. I think Turkey has done a good job. And so one could argue that if the government wished to do something, they could do a lot within the overall health system. I think the government's role in the private sector, unless they are prepared to talk the language of incentives and persuasion and guidance and not regulation, I think it's best that the government stay out of it. Because if you bring in more regulation, the unintended consequences of some of those ideas may be somewhat untoward. And as you know, in India, the government does not see itself in the strict sense of the word as a policymaker. It sees itself as an actor, as a player, as a competitor in the market. So it owns its role as an active player much more than a facilitator of markets. So I would say we are still back to what can the private sector do on its own. And I believe it can do a lot more.
This is fascinating because this is also bringing back a lot of memories from my Bangladesh days. Because as you rightly pointed out, Nachiket, the government sees itself as a competitor in the market and is competing with the private sector, and still it has this overarching ability to control what the private sector does and set policy, right? So there is clearly a conflict between those two positions. If you're a competitor, you should not have the regulatory authority over your competitors. And which is why you're also seeing that despite billions of dollars of investments in public sectors in places like Bangladesh, people are still overwhelmingly flooding to the private sector because the stewardship role is just not there.
I mean, it's an interesting point that Nachiket makes. From the private sector perspective in South Africa, we are very under-regulated. It is very much a free market when it comes to healthcare delivery in the private sector, with degree of regulation, but under-regulated. And the consequence of that has been that the forces of capitalism have driven the evolution of the market. And to Nachiket's point earlier, in situations where the market should organize itself for the benefit of the patient, it has consequently organized itself for the benefit of its shareholders and shareholders alone. I mean, it's overlap and somewhat adjacent, but I just want to say that I do think there's a big role for government to get the playground for private sector right, to ensure that incentives are set up to drive towards what's better for the patient, as well as, of course, to have a sustainable business. Because ultimately, we do live in a capitalist environment where if you make profit and you're doing something good, you can scale what you're doing. It's just that what you're doing should be scaling because it's impacting outcomes and cost rather than shareholder value alone.
Yeah, absolutely. And that is where I think a lot of the countries that have succeeded in this path, right? Like Colombia, maybe not so much a great example anymore, but early on, at least its managed competition model was actually trying to get at that. Thailand's primary care practices are also being funded to drive towards outcomes. So that's, I think, the government role is quite important there. But let's come back to the question that Nachiket posed as well, which is what can we do in countries where government does not play that stewardship role? Companies like Healthforce have attempted that in South Africa. I am most familiar with Kaiser Permanente in the US. What other kind of integrated models are out there that have been really successful, especially in low resource markets? Because I don't see that many models out there in the private sector.
From a South African perspective, there's definitely a desire within the market to create value-based care offerings. Because ultimately, when you're talking about integrated care, you're integrating for a reason, that's to deliver better value. And value in healthcare is defined as better health outcomes and lower cost. And there is a desire in the private sector, and actually, for that matter, in the government sector, where they're talking about bringing in a national health insurance fund to drive towards better value. Despite that, there seems to be very little success in creating any kind of coordinated care that does it in a measurable and significant way. The problem is, let's start with measurable. In a market that's fragmented, in order to deliver better value, you need to measure whether you're delivering better value. And you can only do that, given a patient moves across providers, when data is shared across providers. And so it becomes very hard for us, even as health force, to know when we pick up that somebody's blood pressure is out of range and refer them on to their physician, for example. What happens after that? We don't know whether we made an impact in the healthcare system or not. And there's no way for us to tap into that. For that matter, there's a disincentive in the system for the provider to whom we refer to share that information with us. Because there's a risk then to that provider that I will steal that patient from them when they can keep servicing that patient, even if they're over servicing based on their skill set. It's still income for them. And so there's no incentive for them to share the data with us. There has been an attempt in the private sector in South Africa to create a data sharing platform. And ultimately, I think it fell apart because there was no incentive for the big incumbent players to share their data and risk losing their patients. And frankly, there was no benefit because they didn't really want to refer. They wanted to look after the patients that were in their particular system, even if it was only some portion of the system. So to be honest with you, I've seen it happen in pockets. I think there's some phenomenal startups in South Africa who are trying to get it done. There's a really interesting model by a company called PPO Serve, where they are using GPs as care coordinators and as the first point of contact and coordinating care from there. There's some really interesting stuff done by some of the hospitals around particular episodes, particular conditions. Renal, for example, being an easy one in which you can manage the care continuum. But at a system level, the incumbents are stuck in they need to make money. The money is fee for service, which drives fragmentation, which means you can't measure. And so I haven't seen anything significant happen in our market.
Are you familiar with any other models within the African continent?
I know there's a mutual friend of ours who built something really amazing in Kenya that was working towards something like this, but again, the incentives in the system scuppered his attempt. So I don't want to go into that, but like I just haven't seen anything which has been able to scale in any kind of valuable way. Ultimately, that everyone that tries to do things differently runs into the same problem, which is that you need somebody to pay, and the people that are paying and the people that are providing on fee for service have a symbiotic relationship. And as much as they might want to change, there is no legislative or other force to make them do so. And so if you're trying to build something, you're actually undermining their businesses. And even though you can deliver better value, it doesn't make sense for them to work with you. And often it actually makes more sense for them to actively lock you out or replicate what you're doing themselves without letting you in.
Nachiket, in the Indian market or any other market that you're familiar with, are you seeing models succeed against the incentives within the system and the challenges that Saul was speaking about?
I mean, my experience, frankly, is quite different from Saul's. Both, if you see my paper, I list many examples. In the US, certainly you talk about Kaiser, no question, that's a famous example. Geisinger, which of course now has been bought by Kaiser, I understand. Another example, Brazil has had a number of examples of hospital-led vertical integrations where insurers, providers have come quite close to each other and figured this out. There's also been good movement on primary care upwards. In the US, for example, there's a chain founded by two Indians, as it turns out, called CareMore, which I document in my paper, which actually grew across states. And I think it was bought by Athena as a integrator of insurance in primary care. My understanding is that many markets, people have been trying to figure out how to make this work. And, to Saul's point, one could argue that, and it's an important point he's making, that, capital markets, equity markets are not necessarily friendly to these approaches. I wouldn't necessarily agree with that perspective because, I sit on the board of some large companies. And we clearly see that if you are able to build a health system in which your cash flow become intuitive rather than in a fee for service market where occupancy rate goes to 30% somewhere, 40% somewhere, you're built a tertiary care hospital and now you're doing routine fractures instead of doing liver transplants. it's just not making money. And if you look at price to earnings multiples of these hospitals, they just don't do well. Why do banks do well, for example, as financial institutions? Because much of our revenue stream is steady. I can predict my revenue stream 10 years on. I can't do that in a hospital unless I build an integrated care proposition. Because if I build an integrated care proposition, particularly if you look at tertiary care doesn't have actually patients or customers. It's all episodic, right? You get a heart attack. That's the one time you will show up there. So in some ways, their true clients are their doctors, not the patients. But that's not a happy situation for them because now you're in the race for doctors. You're trying to hold on to them because that's the source from which you're getting your customers. And then the doctors are in their own private races. So I would say, as somebody that, I have 25 years of work in financial markets. I was a banker and a trader. I think that integrated care is the best thing that could happen to equity markets. Now, you might say, if indeed it is the best thing to happen, why is it not happen? And in some markets, you look at Brazil, for example, it's happening on a daily basis. You're getting integrations, mergers. Look at the US. You're seeing so many acquisitions now. The Aetna CVS, the Athena, Caremore. What is this being driven by? Not by charitable interest, but by the desire to maximize value. The insurer makes no money if patients go on falling sick, and they have a deep commercial interest in keeping you well. Now, they could do that by denying you care, but then you will switch to some other provider. You might be taken for a ride 2 times. After that, you'll say, well, what's going on here? It doesn't make any sense to me. So I would submit to you that it's not just a good thing to do from a patient perspective, but from a market's perspective, it will drive better valuation. It will drive better customer acquisitions. It will drive more loyalty for insurers, providers, because you now have a stable name. Now, what is happening in India? I would say, the real challenge in most markets, it's telling if you look at the electric engine and how much time it took to replace the steam engine. After the discovery of the electric engine, it took 100 years. Because there's a lot of inertia in the system, how they have organized. The business case may be obvious, but how do I switch from a culture and whatever it is that I've been doing to something new is harder. But there are interesting experiments on the ground driven partly by large hospitals who, have gotten into insurance and are now trying to build a Kaiser style structure. I'm directly involved with some such efforts. To narrow providers who work in, for example, schizophrenia care, of trying to enter managed care within the schizophrenia film. Right? It has, of course, a higher cost metric. It's different from if you were doing all possible care. But as it turns out, I have a new paper that talks about a schizophrenia insurance product. You might say, how does that make any sense? But it does, actually. To primary care providers. Now, the important thing, though, is, and I think this is what point both of you have raised, and certainly Saul was raising, in a market where everybody is doing fee for service, this won't work. You have to change, because the core issue is, if I'm going to do preventive work, how do I capture the benefits of that? If I don't have a mechanism to capture, if anything, I'm going to lose money. Then I don't have any incentive. But that's a choice I'm making as a provider. Why must I? For example, if I'm a doctor in a neighborhood, why wouldn't I go out there and say, I'm going to build a clientele, of 2,000, 5,000 people that will pay me a monthly subscription. And I will look after them with my health workers. Those are the models that are being pioneered in India. They're growing quite fast. And what they're doing now is and that's the power of primary care. Primary care is the only player that owns the customer. Second care sees them 2% of the time. Tertiary care sees them 0.02% of the time. Primary care sees them 3 times a year, 4 times a year. There is a player in one of the towns in Tamil Nadu that has a patient population of 2 million, which by Indian standards is still modest. Most countries, that would be a large number. They call the shots. Insurers are running around behind them. Hospitals are running around behind them. I'm actually a lot more optimistic, given what I'm seeing, given what I'm directly involved in, that there will be stuff happening here within the private sector. And there is a reasonable amount happening outside India that gives me confidence that there can be progress.
I love what Nachiket says, and I love that you're optimistic about it. And I must admit, the way I'm describing the status in South Africa is the status quo, with all its incumbent structural barriers to change. But I think we're also seeing green shoots here of companies wanting to serve patients better and unlock shareholder value, because I completely agree. Of course, if you can lower the cost of care and deliver a better product, a lot cheaper product that does more for you is always going to be more profitable for a company as well. We are seeing a lot of the incumbents trying to do that against the structural challenges. So I think it's just, maybe we just need a bit more momentum to get over some of these structural legacy ways of doing things. On the primary care piece, you're right. The primary care provider is the one that owns the relationship with the patient. The problem with primary care, though, is it's very low margin business. The hospitals are where the vast majority of funds are spent and where the vast majority of margin of funds is captured. And the consequence is that hospitals have an outsized negotiating power with funders when it comes to saving those funders money when it comes to service delivery. So there's a lot of investment going into primary care, which is also very positive. I think people realize that that is a place to start if you want to change the system. But as yet, there's no new player that's been able to come in and aggregate enough primary care patients at low margin to create a viable business. Always end up needing to sell to one of the other guys or to try capture margin somewhere else, which in some way corrupt their initial ambition.
I'm just going to observe that when you talk about Brazil, South Africa, India, all of these are probably more mature markets than the average low and middle income country, right? And so in the African continent, where I spend most of my time these days, in countries like Bangladesh, which I'm most familiar with, I'm actually not seeing the same enlightened self-interest among the incumbents to say, let's kind of change this current structure and move towards a better equilibrium for all. And it's almost like a local equilibrium, right? Like it's not an optimal situation, but there is inertia around the local equilibrium that is really hard to move. Nachiket, you've written about the hospital first integration and then the reverse integration from the primary care upwards, as you recently mentioned. I am curious about what role kind of context plays in that. So you kind of compared between more mature markets within India versus less mature markets like Bihar. What role does context play, and how much of that context is actually shaped by government policy versus things that we could do in the private sector? Like, are there things that a philanthropist like us can do to actually catalyze those kinds of innovations?
I think these are important questions, but I would argue to you somewhat differently from your perspective that it's in the mature markets where things are the hardest, because people are making money just by doing whatever they were doing every day. Right? There's no real reason to move. For the patient, again, there's no real reason to move because they're getting some service. On the ground in India, as you know, India is not necessarily one single type of geography. The most traction for primary care models is in the most difficult geographies. Let's imagine a situation where somebody has diabetes. In order to get the basic blood test done and the medicines done, they have to travel 4 hours. And not just they have to travel, some youngster has to take them on the back of a scooter and go up and down. Now along comes somebody and says, if you pay me a monthly subscription, I will deliver all these services to you. The financial costs are 1/10. And, many, in fact, if you look at on ground in India, the maximum traction is in the difficult geography. So, which is why I'm optimistic again of somebody who's already got a hospital in that region. And there are 40,000 such hospitals in India. They can enter primary care very easily because now they can complete the circle of care, as it were, for that patient and say to him or her, hypertension, diabetes, mental illness, pain management, anything you need, if you have to recreate it for yourself, it's going to cost you. And the patients see that. It's not an insured environment where people are giving them free services. There's nothing there. And yes, the government is got a service, but people want the private service. So in fact, I would say the opposite. The more challenging the environment, the more there is an actual explicit saving. I've seen rural people do the math in front of me on a piece of paper. They say, if I do this every month, if I have to go here and there, it's going to cost me so much. These guys have shown up and said, for 1/10 the cost. And initially I didn't believe it, but I said, it's so much money saving. Let me try it out. Turned out it was better than what I was getting. And now I don't have to bother my son. I don't have to bother my daughter. I'm just on my own. I don't have to leave my shop. And you know what? I'm actually feeling better. So that's, they not even count that as the number one issue.
If I'm hearing you correctly, Nachiket, so just reflecting also on my own experience building Gion in Bangladesh, I think where we might have gone wrong, if you're right, is we were trying to play within the fee-for-service market with a fee-for-service model, right? And to Saul's point, it is a low-margin business to begin with in a primary care setting. And I think the part that we're maybe ignoring a little bit here is how costly it is to set up a business in a remote environment where the infrastructure doesn't exist, the supply chains are not as mature, right? So it actually erodes the margins even more. That's something that maybe we don't have time to get into today. But to your point, if it was more of a subscription-based model, and if we are able to convince our clientele in these markets that we were actually generating this value for them, then we might have had a successful model. We're also nearing the end of our time. I want to kind of talk about a few provocations that I've heard on integration from a mutual friend of ours, Nachiket, Professor Jishnu Das. So he writes a lot about a few things among many things that he writes about, but one of the things that he's talked about is integration causing monopoly power. And if I'm kind of getting what I'm hearing from both of you correctly, it seems that the monopoly power is somewhat mitigated by more of a competitive environment where there are multiple integrated providers competing for the market, right? People can switch, and that actually erodes the monopoly power. Am I getting that right?
It does, but you have to regulate it well because, at the end of the day, while patient can make a choice, do they have all the information that they need? Is there enough transparency in it? So it's not as if the market self-regulates. In fact, if anything, that creates more of an incentive for a private player in a market like India or South Africa, where there's not much regulation, to enter this market space, because they can do many things that increase their profitability, but might not benefit always the patient. But yeah, so, if I look at Israel, for example, as a market which has made this work well, or the Netherlands that has made this work well, both developed country contexts and much smaller than the countries we are talking about. There is active regulation. That's why it's no longer called managed care. It's called regulated competition. Even though they mean managed care and multiple managed care entities competing with each other, but they want to emphasize the idea of regulation alongside competition.
Yeah, so that is obviously an important consideration, and maybe one of the contextual deficiencies, right? So in some of the markets that we're talking about, that kind of regulatory capacity is not there to manage a managed competition model like this. The other provocation that I've heard from Jishnu is that patients are actually already ensuring their own continuity to some extent, right? They are integrating their own care. They're going to the specialist for a diagnosis and prescription, but then they're getting their sugar tested weekly at the informal provider around the corner. and they're carrying around like a packet of documents from provider to provider. And by restricting choice within a managed care environment, are we doing a disservice to the patient? That is not always very clear, especially in markets where you're also unable to measure outcomes, right? The outcomes are not very transparent. And so it becomes harder to catch when a managed care model is not actually serving the patient. So how would you respond to that critique?
If you look at the here and now and you say, this is what it is, and in that environment, assuming nothing else changes, are patients doing a reasonable job? Jishnu has some very nice work which shows markets price discriminate quite well. Doctors who provide better quality care are able to charge more, which gives you a sense that there is some markets that are working. But I would say that's the very narrow view of the evidence. If I look at, for example, our most prosperous and well-functioning health system state of Kerala, there's a massive burden of diabetes and hypertension, undiagnosed, untreated. Most of these people don't know they have diabetes and they don't know they have hypertension. What happens to this patient base? And it's as high as 30% of adults. It's not like 2% on the margin. To the point where there is an anxiety that will we end up with an epidemic of amputations. If indeed the markets were working so well, why do we have 60% C-section rates? We know that the mother is 3 times more likely to die through a C-section. Why are they doing so many C-sections? Both in the public and private sectors, not just in the private sector. So I would broadly say markets are not working. I have a paper in the Lancet that came out 2 years ago that shows that a state like that, Kerala, government is currently spending enough money to offer universal health care, which means free care to everybody without any insurance in the public sector at all levels, all surgeries, all primary care. And they also have the infrastructure. The question is, why are they not? One of the natural questions, they have the money, why are they not giving it? Well, because they're busy doing C-sections with that money. So, you do need some, this was the core of Kenneth Arrow 1963 point, that first welfare theorem is not satisfying. When I go to buy toothpaste, the reason the first welfare theorem works, Adam Smith's invisible hand, is because I know what I want, at least broadly speaking. When I go to a hospital, I have no idea, none at all. All I know is my stomach hurts. That environment, if I get a cheaper stomach hurt situation, that doesn't mean I got good health care. It might be my kidneys have failed. Actually, a much more expensive thing, which I didn't pick up.
I mean, I must agree. When I think about the healthcare market, so to speak, it just doesn't look like any other market out there. I would probably summarize it in 3 ways. The first is, and Nachiket just touched on it, the first is the information asymmetry between the purchaser and the provider of the product. Nowhere is that information asymmetry as great and as sensitive. Even if you don't know how a car works, you go out and buy a car, you can ask somebody's uncle who knows about cars what they think, or you can research online. But, personal experience, when my partner was pregnant with our first son, and we went to the gynecologist, and the gynecologist said, well, it looks like there might be water on his brain, you're at term, let's do a C-section. The information asymmetry is too great for me to argue against him and put my child at risk. The second reason why it's not similar to other markets is because nowhere else do you have this much spend and very little of it comes out of the pocket of the person receiving the service. The third-party payer is incredibly strong in the healthcare market, and the third-party payer therefore determines, based on what they will pay for, what you will get. And they aren't always aligned in terms of what you need versus what you get. So third-party payer is the second reason why it's not a traditional market. And the third reason actually why it's not a traditional market is a strange thing where at a system level, the more you pay, the less you get. And you can actually get remarkably more by paying less. And nowhere else do you go and buy more, pay for more car and get less car. when you organize the system in an integrated way, you can lower the cost of care. And that makes it also a very unusual market. You can get more by paying less. And so, I mean, just to use the cesarean section as a classic example, I often cite in South Africa. In South Africa, in the private sector, which has these attributes I've just spoken about, cesarean section rate is at 80%. Whereas in the public sector or the NHS, it's at 20%. That means that 60% of the women in South Africa giving birth are paying a lot more and getting a lot less. They're paying for theatre time. They're paying for their anaesthetist. They're paying for 4 nights in a hospital. They're paying for 6 weeks of recovery, and they're getting less. 6 weeks of recovery, 4 nights in hospital, potential complications for mother and child, and so on. So healthcare is, it's also why I've stayed in healthcare for so long. I find it fascinating. It just doesn't look like other markets. It's got a whole lot of different, quite distinct attributes.
Yeah, I think that's a great perspective. Now, of course, you might argue, are there other ways of organizing this so that you get what Jishnu wants, but you also get what Saul and I are talking about? And really, I think, at least in the Indian market, I think some of the new digital technologies start to offer us an opportunity to use digital twins, to use ambient AI, to build kind of a DPI type structure. Because we already have many of the rails. We have the payment rails, we have the information rails. During COVID, India gave almost 800 million people unique health IDs. Can we use all that? And we do have the, digital architecture of e-prescriptions so a lot of it is conceptual or partially implemented, but perhaps there we could get both. We could get both what we want. And now, instead of a GP or a quote unquote a real doctor, now I have a twin that becomes my alter ego. They're already there. If you look at in India, there are companies like Healthify Me, Beto. If you become a customer of Healthify Me, you have a chatbot talking to you, and she's actually your twin. She knows all your data. She knows what's going on with you. She can predict what might happen to you in narrow spheres. So I think there's certainly a bit of a possibility out there where instead of a health worker showing up at my home to chase me to take my diabetes medicine or to chase me to get my, colon cancer screening, I have a chatbot that is pushing me hard to do it because they are conscious that I'm being lax on it. Then build such a structure. I think the insurance market could price much better. Now, can we, with the kind of data a digital system can throw up, really design what I would call insurance for me? Some of my systemic risk is priced like a regular insurance. Some of the unique health benefits that I have because I choose to live like a Himalayan sadhu, I pay less. I get a discount. On the other hand, I have other obsessive compulsive disorders for which I pay more. And I get care in return. I get primary care in return that's customized to me. So that's the glorious future that we can imagine where we get this and that, not this or that. I don't know, Saul, what?
Yeah, I love that. Not either or, both and. And I think that I've often thought about this if an insurer or provider, and particularly an insurer, is starting today with the available technology rather than with the legacy systems they're sitting with, how differently would they construct their businesses? And I think the abilities would vastly outstrip what they're stuck with trying to upgrade, which would allow for the kind of things that Nachiket is talking about.
As you probably both know, I think about this stuff a lot, especially on the digital side. And what you just said, Nachiket, is reminding me of this book I recently read called On Healthcare by Hema Taneja and another co-author that I'm forgetting. But he promotes the concept of what he calls health assurance rather than health insurance, right? Of course, as you said, insurance is for risk pooling and really taking care of those catastrophic but low frequency conditions. But then on a more regular basis, could you provide almost like a health guarantee to people, right? Like if you follow this advice, if you stay on track, we are going to guarantee that you're going to have good health outcomes. And basically use the digital tools and data. And now, of course, we have the power of AI. So if you could have personal health companion that aggregates all of this information, starts predicting your risk, starts intervening at the right time, what would that mean for health outcomes, cost, and the kind of outcomes that you could generate? And that is kind of a sweet spot for also a philanthropy to play a role. So coming back to my earlier question, what parts of this context can be actually engineered, right? Because we can't change what governments do. We can't change how governments regulate these markets. But what kind of environments, what kind of enabling technologies or frameworks can we support from, let's say, a small philanthropy that's trying to help catalyze the space move in this direction? What could we do to move the space forward?
I think probably the most important thing to do is to not create incentives through the funding that you provide that don't align with the eventual incentives when that business needs to scale beyond that funding. So you don't want to be, rehabilitating the panda bear in a way that doesn't allow the panda bear to go back out into the forest afterwards. I think that's absolutely critical for where the funders play. The second thing is it's really important that when you're looking to give funding, you recognize you have a product that you're selling and test and experiment where the product market fit is. So what I mean by that is that if you've got a certain amount of funding and you want to deploy it as effectively as possible, use a fraction of that to check in a fast, in a low cost, in a measurable way, whether there is better fit. It doesn't have to be very expensive. It can be a survey. It can be funding a little pilot project and figure out where you're most likely to get your bang for the buck rather than assuming that you know already, or sometimes that the people that you're investing in know as well.
I'm going to push Nachiket on this in that case, because what you've said, of course, it's very good advice. It doesn't still answer the question of how do we get, like, as a philanthropist, and not just us, right? Like, I'm also representing a broader philanthropic space that's trying to figure out how to do this well in a market where ODA has collapsed. Countries are trying to figure out how to fund their health environment, and they need better value for money, right? If they're going to be funding healthcare from their own budgets, they're going to need to get to better outcomes at a lower cost. So how does a philanthropy play a role in this space without necessarily having control over how governments approach this, but to catalyze the space forward and to get to better value-based care or better integrated models?
I would just add one caveat to Saul's, it depends on the size of the check, but it also depends on your risk appetite. You can have a small check and a big appetite for risk. Then the question is, do you bring a vision to this? Do you have a set of partners, that are there? Can you break down this journey into pieces? Can you build public goods and see whether they catalyze the market or not? And some of these things don't cost a lot, but require a lot more thought, a lot more imagination, a lot more collaboration to make happen, and a lot more willingness to say it won't work. And I want to shift the market. So I don't want a good fit with the current market. I don't like the market. I want to switch the market. And that needs a very different type of effort.
That's very well put. And that definitely characterizes us quite well. I can't speak for other philanthropies on this, but from our perspective, we definitely see a lot of these gaps in the market, and really we want to shift it. And the approach that we've taken so far is to have like high risk but potentially catalytic bets on local ecosystem players that are really trying to change the space and to build the right kind of enabling technologies and tools and digital public goods. for that. So we are nearing the end of our time today, but as your concluding remarks, if you would like to reflect on anything that we talked about, and in particular, if you would provide any advice to governments or to innovators locally in these markets on how to really start this journey towards better integration or better value-based care. Nachiket, I'll come to you first.
As I said earlier, I'm actually quite optimistic that a lot can be done. I do think there is a lot that is possible, and I'm certainly hoping to drive some of this. I think my advice, if at all I can be so bold, to investors, governments, private equity players, is to recognize that healthcare is a different market. It is not a consumer good, though it may look like one. It may look like, in the first welfare theorem, we have this, kind of important issue, which is the market competitive and efficient? It may be competitive because there is a price, but it doesn't mean it's efficient. And you're required to lean against the wind. You can't follow the market. You can't say, this is what is happening, let me just stay with it and do a little bit on the sides. And at least countries like mine, I think we have a wonderful opportunity. We still don't have the obesity epidemic to the same degree that the developed world has. There are states in India, they have low burdens of diabetes, low burdens of hypertension, low burdens of cancer, low burdens of mental illness. Now, they will get there. I'm not saying that if you do nothing, they will get to where everybody else is, but they have a choice to actually do something else. So that's what I would say.
Thank you for that optimistic note, Nachiket. Saul.
I suppose I've got thoughts on both the product and the customer acquisition side of it. Both seem to be points of failure in some of the startups trying to change things in the healthcare space. On the product side, I think it's really important to be wedded to the outcome, not your solution. So I've seen a lot of situations where people will try hammer their solution into the hole, even though their solution is a round peg, and eventually they realize it's a square hole, but they just keep going anyway. So don't be precious about your product. If the outcome you're trying to achieve is a change of incentives or is a particular health outcome for a particular condition, be fluid. You're learning and adapting. That's the first thing on the product side. On the customer acquisition side, I think a really interesting approach is, especially if the incumbents in the market that are, financially benefiting from the status quo, is to find a company that has a lot of customers that's adjacent to the market that wants to enter the market and piggyback on them. And that, I think, is probably where some of the greater change is likely to come. Healthcare is in every country, somewhere between 4%, in South Africa, it's 8% of GDP. It's a massive amount of money spent there. There are a lot of companies that have data on people that could give them a view on their health, that could make money by moving into healthcare. Tailors, banks, minnows, and so on. So if you can't muscle your way into the value chain because of incumbents, customer acquisition through a partner who's adjacent that wants to enter, I think, is a way to potentially drive scalable change.
Thank you for those very actionable pieces of advice. Thank you both. This has been, as I expected, a very rich and enlightening conversation. I hope our audience will enjoy it as much as I did.